Alright, we're going to do a quick video on clavicle fractures, and we're going to start off this video with a quick clinical case. Anyway, you've got a 25-year-old male that presents to your establishment with a complaint of a fall approximately 1 hour ago with some tenderness to this area of the clavicle. The patient appears to be in no significant distress, right? And the question is, what should you do? Your choices are to palpate for the fluctuance and incise and drain the abscess, x-ray the patient, put him in a figure of 8 splint, send him home with an orthopedic follow-up, or C, order imaging, sling the patient, and send the patient to the emergency department for an emergency orthopedic consult for reduction of the clavicle fracture. I want you to stop and think about this and make a decision on what you would like to do. And then we'll continue from there. Simply pause the video, think about this, write down your reasoning, and we'll start up in just a few seconds. And the answer is order imaging, sling the patient, and send the patient to the emergency department for an emergency orthopedic consult for reduction of the clavicular fracture. And the reason is there's tenting over the skin, and even though it may not seem like a significant amount, the fact is this little area over here right now, if you were to look at it sideways, there is a piece of bone pressing on the skin. And this area right over here under the skin is going to have decreased capillary refill. And essentially, we all know that the pressure inside the capillaries is approximately 15 millimeters of mercury. And it doesn't take much to decrease the blood flow, and the skin starts to die. And if you want to prove this yourself, simply take let's say that pad of your finger and press it really hard onto a hard surface, and what you start to see is this part of the finger becomes pale and eventually becomes extremely painful. This is similar to a decubitus ulcer. Feel free to test any body part you like on that. Elbows, knees, heels are particularly good for that. So anyway, the point is that this is really one of 2 emergencies for a clavicular fracture. The first is tenting of the skin, which for obvious reasons we've talked about, and the reason is that tenting of the skin will cause a necrosis of the skin, which will then cause the skin to break down, which will then convert this from a closed to an open fracture, which is generally a bad idea. The second is neurovascular compromise, and the reason that neurovascular compromise is important, needless to say, is that if you have no blood flowing to your upper extremity or significantly decreased blood flow, you can end up with ischemia to the upper extremity, which will result in an afunctional limb. Additionally, the other emergency would be, in regards to neurovascular compromise, would be some sort of compression of the brachial plexus. Now, in general, if a nerve is contused briefly, so if you strike it, you may end up with sort of like, a Saturday night palsy. You'll have essentially it'll feel like you hit your funny bone. But the big concern is if there's constant pressure on that nerve, is that you can necrose that nerve as you decrease the blood supply to that nerve. And especially this high up in the area of the brachial plexus, that nerve really will not grow back. And then, of course, the third emergency is an emergency with any sort of fracture, which is an open fracture. So let's move on to see why this is so.